Dr. Litzow, thank you so much for joining us on MD Newsline. Please, for those of us who aren't familiar, introduce yourself to our audience.
Sure. My name is Mark Litzow. As you said, I'm a physician and a professor of medicine at the Mayo Clinic in Rochester, Minnesota. And I was the chair of the ECOG-ACRIN Leukemia Committee for 9 years until 2022.
Yeah, and I know your work is has been cited here, and someone's going to present some kind of continuation of work you did on a trial, the ECOG Akron E1910 trial. But I wanted to talk to you a little bit about the concept of clinical trials versus real world practice, because of course at a conference like this we're naturally talking about clinical trials a lot. There is some conversation about outcomes for patients being treated in routine clinical practices being similar to those um, in clinical trials. What do you see as the key factor that enable high quality outcomes in real world settings, and how can this be replicated more broadly?
Well, real world settings do bring some heterogeneity because with a clinical trial, there are eligibility criteria. So there is some, I'll say, some control over the types of patients that are enrolled, whereas in the real world, it's more heterogeneous. And sometimes, people say, and we've found that
Mm,
sometimes what we find in clinical trials doesn't necessarily replicate in the real world because sometimes those, patients, they can be sicker or have other comorbidities that can influence their outcomes as well. But I think real world evidence is playing a more prominent role in our ability to understand how these treatments work because we can't answer every question that we might have in a clinical trial. It's not possible, and clinical trials are expensive. They cost millions of dollars. So real world evidence can kind of give us, I'll say, a reality check on what we find in clinical trials and does it translate into what we see in the real world.
mhm. What are some of the limitations that clinicians, for instance, should be aware of when interpreting real world evidence studies?
Well, I think they have to look at the patients, the characteristics of the patients that are included in those studies. And so I would say drill down in the details of those publications to garner that information. And, if they're comparing and contrasting one real world evidence study from another, then to look at the differing characteristics to see if some of that information can play a role in the results that are being seen.
Hmm. Has this kind of rise of real world evidence changed how you approach treatment at all? Has anything really stuck out to you or inspired you in the realm of real world evidence studies?
Well, I think it's helped me in most instances, confirm what we found in clinical trials, but there's also been situations where we have, found differing results. In a different leukemia than I worked with in my E1910 trial called acute promyelocytic leukemia, we did a study where we advised community oncologists um, in managing these patients with called APL, acute promyelocytic leukemia. It's a very rare leukemia, so community oncologists don't see it very much. And a lot of the patients that we managed on that study, they came from the community and were not, we didn't have specific eligibility criteria. And those patients wouldn't have been included in a lot of the clinical trials that we saw. And there's an early death rate with APL, unfortunately, that is not taken into account in clinical trials.
Mhm.
So that was an area where that was real eye opening,
Mm.
for me.
Yeah, let's talk a little bit about measurable residual disease assessment. That's becoming more central to risk stratification and management in ALL. For example, how do you integrate MRD results into your treatment decisions, and are there challenges? What are the challenges? Because I'm sure there are in standardizing MRD testing across institutions.
Well, that is a challenge, particularly with what's been the most common approach in the United States is flow cytometry, and that isn't in adults not well standardized across different adult populations. Each institution has their own assay, and they haven't frequently been compared one to another. Our pediatric colleagues have done a much better job with that. There are basically two labs in the United States, one on the West Coast, one on the East Coast, that do the MRD testing by flow cytometry for the children's oncology group. So they've standardized that assay. So that's one of the challenges in adults is that the results haven't always been standardized. Now there's another test, next generation sequencing, which is a more sensitive test. We can pick up 1 in 1 million leukemia cells, whereas with flow cytometry, we can pick up, 1 in 10,000, maybe 1 to 100,000. And that assay, it's actually that this NGS MRD assay has been, it's commercialized. So there's one company that does it in the United States. And so they've got it standardized. And that's actually becoming the gold standard, given its increased sensitivity and its ability to be standardized. But it does require getting a sample from the patient at diagnosis. And that can be from a bone marrow slide, so it doesn't have to be the day they have their diagnosis, but that sometimes can be a challenge.
Mhm. So when it comes to things like genomic risk profiling, that's being used more to guide therapy in things like ALL, how do you see the role of molecular and cytogenetic risk evolving in clinical decision making? And are there subgroups that you've come across that might benefit from more tailored approaches like this?
Well, up to now, much of the risk assessment that we do with these molecular genetic tests is based on results that we've gotten in patients who've gotten chemotherapy. And we can categorize patients as having more favorable risk, genetic abnormalities, sometimes intermediate, and then unfavorable. And the unfavorable patients obviously don't tend to do as well with chemotherapy. So in the past, we've always felt that those patients should be considered for a bone marrow transplant, even if they have a good response to chemotherapy and become MRD negative, where we can't find any evidence of leukemia. We're still worried that there's leukemia cells hiding there that could cause a relapse. Now that's changing somewhat with the introduction of immunotherapy, immune therapy approaches, which is looking like are going to be able to overcome some of those um, unfavorable genetic abnormalities. And we're starting to think that maybe not all those patients necessarily need to have a transplant if they get treated with immunotherapy and become MRD negative.
Mhm. I'm curious about just the concept overall. Speaking of, pediatrics or younger patients, I came across just in some of your writing mentions of the adoption of pediatric inspired intensive chemotherapy regimens in young adults to improve outcomes in ALL. What are the most important considerations when adapting these regimens for older or high risk adult patients?
Well, it's to know that the pediatric regimens, now the big difference between the pediatric regimens and the adult regimens are that the pediatric regimens use much more of what we call non-myelosuppressive drugs. So drugs that don't cause the blood counts to go down as low. And those are steroids, a drug called vincristine, and then a drug called L-asparaginase.
Mm.
So those are used in more frequently and in higher doses in the pediatric regimens. But in young adults, they don't tend to tolerate those as well. So they can have more side effects, more complications from those. So that's an important consideration to be aware of that and carefully monitor those patients. Probably as well as the pediatric patients or more should be carefully monitored using those regimens. So they're not easy regimens to get the patients through. We can get them through them, but it takes a lot of careful care.
And what strategies do you find most effective for monitoring and managing treatment related toxicities, specifically hepatic and neuropsychiatric effects?
Well, it's an important one is frequent follow-up. So we have to help our help our patients be compliant, show up for their appointments, and show up to have the testing that we need to do to make sure that we're carefully monitoring those things. There's different approaches that have been taken to assess the neurologic and psychiatric effects, even something called a writing test where they write a phrase every week and we can see if that their handwriting is deteriorating. That could be a sign of a neurologic problem. So those kinds of things are important.
Yeah. So I'm excited to talk about this ECOG-ACRIN E1910 trial. Can you just give me an overview of the trial? I'm really interested in understanding the rationale and behind the trial and everything like that. How did this come about?
Well, we've known for some time that we're reaching the limit of what we can achieve with chemotherapy. Trying to increase the doses of chemotherapy leads to more side effects, and we're not getting as much benefit. At the same time, immunotherapy was coming to the fore, and there were several immunotherapy agents that we were starting to see become available. And one of these is blinatumomab. And blinatumomab is a bispecific T-cell engaging molecule. And by that, it means that it combines the active area of an antibody that reacts against a protein on leukemia cells called CD19. And it's linked to an active part of an antibody that is called CD3 that reacts against CD3 on T cells. T cells are thymocytes. They're a form of lymphocyte, a part of our immune system. So blinatumomab brings a T cell in close proximity to a leukemia cell and kills it. And it was found to be effective in patients where their leukemia had come back, where they'd relapsed. And then we also found that it was active in patients that were MRD positive. So they went through chemotherapy, they went into what we call a regular remission, but we could still find evidence of leukemia. So we said, well, there are patients that become MRD negative, do overall pretty well with chemotherapy, but we know their leukemia can still come back. So we wanted to see if blinatumomab could lessen the risk of leukemia coming back in the MRD negative patients. And so what we did was we enrolled 488 patients. We gave them chemotherapy to get them into remission. And then if we found that they were MRD negative at that point, we randomized them to get 4 cycles. And blinatumomab is given by a continuous infusion for a month at a time. So that's 1 cycle. So we gave them 4 cycles of blinatumomab plus also a conventional consolidation chemotherapy. We're consolidating their remission. And the control group got that same 4 cycles of chemotherapy. And so we compared the outcomes of those 2 groups. And we found that at about 3 years, the survival was much better for the patients who got blinatumomab plus chemotherapy. It was 85% versus 68% for the patients that got chemotherapy. So we found that adding the blinatumomab, which is easier for patients to tolerate, definitely helped people do better.
So considering these differences in survival rates, what do these results suggest about the impact of adding immunotherapy to consolidation therapy for MRD negative patients, and how might this influence standard of care going forward?
Well, of course, it showed that survival was improved, and it's now become the standard of care. And the company that makes blinatumomab, they submitted the data from our trial to the FDA, and the FDA approved another indication for blinatumomab. It was already approved for relapsed patients. It was already approved for MRD positive patients. And now they approved it, and they just said in the consolidation phase of chemotherapy. And basically that's going to encompass these MRD negative patients.
Mm.
So that's exciting that we now have this additional treatment that we can give to improve patient survival. It's also suggesting to us that by having this available, maybe we can cut back on the chemotherapy that we're giving and give less chemotherapy and rely more on the immune therapy to help keep the patient's leukemia in remission. And there's already some studies in older patients where we've combined a couple different immunotherapy treatments, one of them being blinatumomab, without giving any chemotherapy, and we're seeing good results. In younger patients, we're not ready to abandon chemotherapy because they still can have good outcomes with this treatment, but we think we might be able to cut back. And so that's what's going to, I think, be a future avenue of research and a future goal to lessen the amount of chemotherapy and lessen some of the side effects and improve people's quality of life.
Hmm. There was a slightly higher incidence of neuropsychiatric adverse events in the combination group compared to the chemotherapy alone. How should clinicians balance the survival benefit with the increased risk of neurologic or psychiatric toxicity, particularly in older adults, I think?
Well, this is a known side effect of blinatumomab. We don't understand completely the mechanism. We think some of the maybe these T cells that get activated may actually get into the brain area and impact that. Um, so I think clinicians need to be aware of this and monitor patients for it. It's not, fortunately, life-threatening, and it is reversible. Uh, Oftentimes, the blinatumomab needs to be either stopped completely, or sometimes it can be stopped and then restarted at a lower dose. So I think it's just important for clinicians to be aware that this can happen, monitor their patients for it, and then be proactive in managing it.
So the trial allowed for maintenance therapy and allogenic transplantation. How did these factors interact with the primary findings, and what are some of the implications of sequencing consolidation, maintenance, and transplant strategies in this population?
Well, we at the time we designed the study, we weren't sure that transplant was still going to be needed or not. We thought that it likely still was, and so we left it to the doctor taking care of the patient whether he wanted to consider the patient for a transplant or not. We didn't mandate that this patient needed to have a transplant or this one did not. So we left that to the discretion of the investigator. Now, I mentioned earlier that we've always thought that patients with high risk genetic findings should have a transplant, even if they become MRD negative. We're starting to rethink that and thinking that maybe some of those patients may not need to have a transplant, so they could be closely monitored. So the results of the study may impact whether patients have transplant or not. Now, a less known fact about the study was we wanted the patients in both groups, the blinatumomab plus chemotherapy and the chemotherapy arms, to have the same total amount of therapy. And so the patients that got the blinatumomab plus chemotherapy actually, when they finished their consolidation, they got maintenance treatment, but they got less of it than the patients that got chemotherapy. And despite that, they still did well. So we're starting to think that maybe maintenance therapy is not as important as we thought it was. And again, we're not ready to necessarily abandon that in younger patients, but it's a key question: is do we know whether we can shorten maintenance? Could we even possibly get rid of it altogether?
Hmm. So younger patients had the greatest benefit from the blinatumomab, but older patients also showed improved outcomes. How do you individualize therapy for older adults with ALL, particularly regarding immunotherapy and asparaginase use?
Good question. So from what we know now, and remember E1910, the 10 in E1910 meant the study was approved in 2010. We didn't start enrolling patients till 2013. But what we know now is that probably the E1910 chemotherapy is not ideal for older patients. And I mentioned earlier that there's been some studies where we've used immunotherapy alone. So I think for an older patient, I'm not necessarily sure that I would automatically treat them with the E1910 regimen. There are some studies looking at either low dose chemotherapy, or there was one study I mentioned where no chemotherapy was given. So I think the approach in older patients is going to be to rely more on immunotherapy, either without chemotherapy or using low doses of chemotherapy.
Mm. So I want to switch and kind of talk a little bit about translating research to practice. Given that clinical trial populations differ from the broader patient population, what advice do you have for clinicians when applying findings such as those from E1910 to patients with comorbidities, or those not meeting strict eligibility criteria? We discussed this a little bit, but are there any kind of areas in that question that we haven't touched on yet?
Well, I think that what that really tells me is that treatment needs to be individualized. and every patient's a little bit different. So I think that immunotherapy is become and has become an important component of the treatment of ALL, and I think it should be incorporated into the treatment. I think dealing with the older patient or the patient with comorbidities, the bigger challenge is what to do with the chemotherapy and whether to go with lower doses of chemotherapy, shorter duration, and that's where I think things have to be individualized. So that would be my advice to clinicians would be to try to maintain the immunotherapy as much as possible, and then modify the chemotherapy as needed to minimize side effects and maximize benefit.
And with immunotherapy being approved for MRD negative consolidation, what are the biggest unanswered questions in this field from your perspective? For instance, do we know the optimal duration of immunotherapy, or the sequence, or how to sequence it with transplantation and maintenance? What do you think are some of the biggest areas that need to be focused on?
Well, a big one is how much immunotherapy is needed. So in E1910, we said give 4 cycles. Now, not all the patients got 4 cycles. Some of them couldn't make it to that because of side effects or other issues. Um, there are some studies showing that as few as 2 cycles. Now, this is a study that was done in pediatrics in younger patients, and these were what are called standard risk pediatric patients. So, people are asking, would 2 cycles be enough in adults? Can we extrapolate from the pediatric results? And I think we have to be cautious about that. So I think we don't know what the optimal number of cycles are. I mean, there are some studies where they've given up to 7 cycles of blinatumomab.
Mm.
Blinatumomab is expensive, and particularly in resource stretched areas of the world, it's too expensive to give that much blinatumomab. Remember, I said it was also given for 4 weeks. Some people have asked, well, would 2 weeks be enough? Do we need to give the full 4 weeks, or can we get to MRD negativity with, say, or get to MRD negativity or maintain MRD negativity with 2 weeks rather than 4? So I think the duration of treatment is probably the biggest question. A second one is, how much can we cut back on the chemotherapy now that we have immunotherapy available?
Mm. How do you see the role of MRD evolving as both a prognostic and a predictive biomarker as more immunotherapies become available? Do you?
Well, I think it's going to play a continued role. I think we're going to get more patients to MRD negativity. And so we'll want to have the capability to assess for that. And then the MRD testing is also important for monitoring after patients are done with treatment. Because if we can pick up an early relapse before it becomes full blown and makes a person sick, then we can intervene with other therapies and get that back to MRD negativity, get the leukemia back under control before it creates more havoc.
Mm-hmm. Have you seen, because we have these conversations about cancer specifically and rates increasing in different populations. Have you seen any changes in your practice in the age of cancer diagnosis, or anything like that from your personal practice experience? Or is it mostly steady in
Well, I
your?
wouldn't say so much with ALL. Now, there is one subset of ALL that we're seeing more increasingly, and that's in patients with multiple myeloma
Mm.
who go through treatment. They get on maintenance treatment with something called Revlimid.
Mm.
And we're seeing that a number of those patients are developing ALL, which is kind of a surprise to us. So that's something new. Um, in the broad area of cancer oncology, we're seeing solid tumors develop in younger people more often, which is not something I personally have dealt with, but I've read about, and I trained in oncology, and that's really, how I'm going to say, throwing oncologists a bit off balance, to see young patients with, say, metastatic colon cancer, which is a tragic thing to think about. But um, and to get at your
Mm.
question, that's one other area that I think about.
Yeah. Yeah, that's definitely been an area that has been coming up. So, looking at this study, phase 3 study, we're, continuing some subsequent studies, one being presented at this conference referencing your work. I've had a lot of conversations about the use of artificial intelligence and machine learning to analyze data from past clinical trials. And so I'm wondering if you have had or conversations about or thought about how this clinical trial might be used in that regard in the future, or if that, ha- is going into any of your current or future work.
I can't say that it currently is, but I think it's an area that we should think about and pursue. The study that's being presented here at this meeting is looking at the younger patients on the E1910 trial and how they did. So that's what we call, a secondary analysis from the study, and we have many of those. There's many questions that we can ask about E1910 and try to look at some other aspects of the study and see what
Mm-hmm.
other information we can glean. So I think artificial intelligence could definitely, play a role as we continue those efforts. And I think um, when we do what are called meta-analyses, where we combine, try to look at the results from multiple studies to see if looking at a larger number of patients, can we detect any, subtleties or nuances that we don't see in one individual study? And artificial intelligence could certainly play a role there.
One thing that I think about just in combining these kind of last two questions is this conversation about cancer rates increasing. We're moving more towards more personalized medicine, and there seems to be a lot of siloed information among specialists. The oncology people are only focused on oncology, but we do have these increasing rates coming up, and we do know that diseases are multifactorial, right? So how can we, just in an ideal world, have these more multifaceted conversations when it comes to kind of understanding how disease develops? Because the body is one ecosystem, yet we look at it in these siloed ways, and the answer to why something is happening, like an uptick in a type of cancer, things like that, is my thought is that if the answer, understanding it, doesn't only exist in from an oncology perspective. And so we do have all of these trials that are going on in different silos, and I'm wondering, it feels like we're missing a lot of opportunities for insights across specialties. Uh, and so I'm wondering, I know doctors are very busy. There's so much information that it feels like we're kind of missing these kind of like intersections and insights. Do you have any thoughts on how we could possibly have those kind of cross conversations?
It's a good question. As we've gotten more specialized, and there's more data out there to absorb, you know, to for someone to really stay up to date and on a particular disease becomes increasingly difficult, and so it does lead to more um, development of silos. So I think if we can counteract that and make sure that we have cross-disciplinary discussions, I think that would be helpful. Um, uh, I think the cancer biologists are definitely people that can help us in this regard, because they're the ones that are helping to look at the how cancer develops, and there's certain similarities from one malignancy to another. Um, I mean, I know, some of the agents that we use in acute leukemia, they're we're looking more at them targeting specific gene abnormalities, and some of these gene abnormalities are also in solid tumors. There's one called isocitrate dehydrogenase, we abbreviated IDH, and that's also found in brain tumors.
Mm,
So some of these treatments that we're using for AML are also being used
mm,
in treatment of brain tumors. And there's some what are called stromal tumors in the gastrointestinal tract that are also sensitive to some of the tyrosine kinase inhibitors, are called, that we use for chronic myeloid leukemia.
Mm,
So I think also keeping those things in mind, and then again, that's where the cancer biologists can help us too. But I think just keeping that perspective of the need for
mm.
cross-disciplinary approaches is going to be helpful.
Yeah, I always wonder about, the doctors tend to have like a very linear thought process when it comes to disease, and I'm starting to feel like we need more nonlinear conversations, like for instance, the topic of inflammation always comes up, and it's because I talk to doctors across specialties, I hear a lot of themes, and I'm like, okay, well, there's a lot of conversations around inflammation, but it almost feels like the inflammation is the topic of inflammation. I don't know how inflammation maybe plays a role in your work, but it's almost like that's secondary, but it's part of some of the most common denominators. Yet it's always kind of discussed and analyzed from a secondary perspective. And so I'm wondering, it feels like some of the factors that lead to the disease end up in the background,
Hmm.
um, which feels like it creates a blind spot for treating the disease because we're kind of coming at it head on instead of like looking at it from a bird's eye view. Um, I don't know if you have any thoughts about that, but
Well, I think inflammation is has become much more prominent in discussions, and so I think that's changing, and I think the role of inflammation in developmental malignancy. I mean, we never used to talk about that I remember,
yeah.
and it's always kind of with autoimmune disease or infection. So I think that is changing in the milieu of looking at how cancer develops. So I'm hopeful that that won't be secondary; that'll move up to a more prominent role.
Any parting words for practicing clinicians as we wrap up our interview?
Well, I hope that they're as excited as we are about the improvements that we've made in the treatment of ALL. There's some other types of ALL that have also, for example, with blinatumomab, have changed the landscape and now made what used to be one of the worst types of ALL, one of the better ones. So I think just for them to keep abreast of these changes as best they can, I certainly admire the community oncologists who are trying to keep up in treatment of multiple tumors.
Mm,
So just to keep those in mind and try to keep abreast of the new developments and be aware of them and either have them help in their management of patients or help them know when to
mm.
refer to let's say a subspecialist.
Perfect. Well, this has been a great conversation. Thank you for sharing your time with us. It's been a pleasure having you.
Well, thank you. It's been an honor to be here.
All
Thank
right.
you.